Welcome to tonight's webinar, The Role of MicroPulse TLT and Continuous Wave TSCPC, utilized in combination with other surgical glaucoma procedures. My name is Kevin LaMarche, and I'll be the moderator this evening. Tonight, we have a stellar panel member to talk about their role and their experience with utilizing both MicroPulse and continuous wave transscleral cyclophotocoagulation in combination with other glaucoma interventions. We have Dr. Sebastian Heersink, Dr. Rajen Desai, and Dr. Courtney Bovee tonight with us. Dr. Heersink is going to lead us off tonight. Dr. Heersink did his residency at Wills Eye Hospital and is a general ophthalmologist with a surgical practice in Dothan, Alabama. Dr. Heersink has performed over 500 MicroPulse TLT procedures, most of them in combination with other MIGS procedures. He is also an investigator for multiple clinical trials and various MIGS devices, as well as a glaucoma drug delivery systems and developing cataract technologies. In today's talk, he will discuss how he combines MicroPulse TLT with other MIGS interventions. Dr. Heersink, it's all yours.
Great, thank you. Great, thank you everybody for coming. Definitely a pleasure and honor to be here together, and look forward to having a really good discussion about all the different experiences. And I think we've got a great panel assembled. So I'm just going to jump right in. Here's my financial disclosure page. And the perspective I kind of want to share is a little bit different. I'm primarily, a cataract surgeon who tends to do a decent bit of glaucoma surgery, and usually in combination with cataracts. Kind of been through the whole progression, starting with an eye stent, when it first became introduced. And I think it's just such an exciting time to look at all the different options that our patients can benefit from. And today we're really going to spend a lot of time talking about the MicroPulse TLT. So many of these things may be review for anybody who's using them, but just to quickly go through the benefits of the TLT. And the first thing is safe, and that's something I really want to emphasize. Is a very pretty extensive experience over the last several years, and it's safe. Non-incisional, patients definitely respond well to that. Effective, repeatable, and durable. So that checks a lot of boxes. The goal is with all the MIGS procedures is to reduce the drop burden at the time of also lowering intraocular pressure. And that's for my patients a big thing, because they're really coming to see me for cataract surgery. They may be on one, possibly two medicines. And if we can get them off drops, that's a tremendous benefit. The flexibility is terrific. Can be used in the ASC, it can be used in the hospital, it can even be used in the office. The other options are, the things that are wonderful is a standalone procedure or combined with any other glaucoma treatment. It's a long-standing CPT code, and we're going to talk about basically all types of glaucoma. It's not just open-angle glaucoma, which with some of the stenting devices you're limited. It's as Dr. Bovee and Dr. Desai will talk about, NVG, all the options. So lots of data supporting, success rate defined by 20% or greater IOP reduction, 60 to 80% success rate. Oftentimes gets into 30 to 45% IOP reduction. And durability. So there's studies showing up to 72 months with 3 retreatments of continuing to keep patients' pressures under control. And learn this preparing for the webinar, 180,000 patients treated in 80 countries. That's a tremendous record, showing lots and lots of use. And the thing I really like, it doesn't interrupt the conj, it leaves all the future treatment options open. So I personally don't do any trabs or tubes or the real glaucoma surgery. So our glaucoma colleagues are very happy to say, yeah, while you're doing the cataract, do your thing, but please don't take away my options for the future. And then repeatability. I personally used it 3 times in a few patients, and with increasing power, and the effectiveness is quite good. Here's a list of the references, which are on the website from Iridex, and settings for use. So first thing is to use a coupling gel. You want to make sure that the energy is getting through the conjunctiva, through the sclera. Typically I treat usually both hemispheres, superior and inferior. Try to avoid the nasal and temporal area, so about 75 degrees. And you'll see some videos later in the webinar. And the time is 50 to 80 seconds per hemisphere. When I first started using it, the settings were a little bit less power and was moving a little bit quicker. So we do about a 10-second pass. But as we've gotten more experience, we go a little bit slower, seems to do a better job of reducing aqueous production, a little bit better energy delivery. And then also the power range has gone up. So typically what I do is for standard cataract surgery with a TLT will be about 2250 milliwatts and 60 seconds per hemisphere. So I make 3 passes, down, back, and down again. And it's set on the duty cycle of 31.3%. In terms of post-op regimen, so there's no incision if you do it as a standalone. I do it mostly in combination. As a standalone, I typically will use a steroid drop. Pick your favorite steroid 4 times a day for a week, then twice a day for a week, and that pretty much does it. Most of the surgeries I do are combinations, and they're there for cataract surgery, and this is kind of an add-on. And I'll use the typical, whatever the cataract surgery regimen. So whether it be an intracameral antibiotic steroid and more than 3 drops. For my patients with cataracts, I typically use an NSAID in all of them, just to try to reduce CME. So I would think if you were not using an NSAID and you were going to use a TLT, using an NSAID would be advisable. So this is the Gen 2, or the newest generation of the handpiece. It's a nice improvement, less irritation for patients. The ergonomics are much improved. And so here it shows basically you want to go in the inferior hemisphere, aim towards the center of the eye, and you step on the foot pedal and do an arc about 20 seconds. And there's these little kind of indentations, we call them bunny ears, and you point those towards the limbus. But it's very simple and straightforward. Once you see it, it's a quick simple thing. All right, so my thoughts are, as primarily a cataract surgery, a cataract surgeon who's doing mostly cataract surgery, combination. The patient population that I see is we do a lot of co-management. So a lot of patients will come in they're sent for cataract surgery, and they may be on a drop, and the optometrist who sends them may or may not even mention pressure lowering to them. But I love that any of the glaucoma procedures it's able to be combined with. Just as an FYI, and this is something more for the administrators, but there is a payment reduction for multiple procedures, so just be aware of that in combining. And patient discussion for me is usually quite simple and straightforward. I think I use the analogy of a sink that's overflowing, the pressure is too high. So I say we can do 2 strategies. We can turn down fluid production. It's like turning down the faucet on your sink. Patients get that. And we can also combine that with opening the drain. So everybody's had a clogged sink, and it's an analogy that I think really rings true. The first thing, you turn off the water, then you figure out and unclog the drain. And patients seem to really understand that basic, simple concept quite well. I've got a lot of experience over last several years, combining with all kinds of all the different available shunts and canaloplasty and goniotomy, even one of the devices that's no longer available. And the beauty I tell patients is it takes 2 minutes. There's no added drops. There's no added post-op medication. There's no added post-op visits. And for me, as the majority of our patients are co-managed because they travel from certain distances, having patients' eyes that are not going to be inflamed, that are not going to have pressure spikes, that are not going to have a lot of the complications, hyphemas and other things is super important. So, and experience has been actually terrific with the TLT. So it's not given us, we're not having patients come back from the optometrist because they're sent for significant issues like CME or other things. Patients understand it going in. My regimen is often to give them an intracameral injection of antibiotic and steroid. So I'll talk to them, and so you're going to experience a floater. I like to use the Trimoxy injection from Imprimis, or the Dexacu, which is recently approved. So they'll see some floaters and blobs, and so they're already expecting to have a little bit fuzzy vision for the first few days. But the combination, it's something. And it's just simple, easy, patients understand it, and not having some of the complications. And that's the big point I think I want to make in the webinar, is that you think transscleral laser, from residency days, big bad scary, eyes losing vision, but it's really several hundred cases just have not seen that, not experienced that. So one of the things also in terms of efficiency, there's a lot of different ways to do it. The way I do it is in our ASC, we actually have our anesthesia team is wonderful, and they block the patients, give them a peribulbar block. So I'll do the CPC laser in the preoperative area while they're getting the room ready for the next patient. So I'll do the CPC, I'll go to a different room, do the cataract surgery or whatever else, and then that patient will be ready, enrolled in the room. So it'll be just like another cataract surgery with whatever MIGS procedure that's there. So from an efficiency standpoint, that seems to work quite well to separate it. You can also do it in the OR, but depending on your setup, it may be worth looking at and evaluating using it in the pre-op area. So kind of a couple more points about my experience. It really is safe and it really is effective. It's a terrific thing, and keeping it really simple. Patients like it. I like it. It works well. They have good outcomes. Their eyes are not flamed. They're not hot. They're sent back to the referring docs, and I make sure to send a note with them. But oftentimes, I don't think the optometrists know that anything different was done. If they don't do a gonioscopy, they wouldn't see any of the goniotomies or canaloplasties, or so they're treated just like every other cataract. And so that's something that I think as cataract surgeons, trying to get these patients better treatment, better care, allow them the opportunity to reduce their drops, allow them the opportunity to lower the pressure. I think you're there anyway, and that's what also resonates with patients. We'll give you some numbing medicine, adds a couple minutes to your procedure, but if it can reduce you or get you off drops, it's time very, very well spent. So the risk benefit is a no-brainer for most patients. So as my experience grew, started using TLT more and more and more, started using it earlier and earlier in the process, and slowly have kind of titrated up on the power. And so it means longer duration, increasing the power, and particularly moving slower, because that really will help the energy do what it's intended to do. So excuse me, sorry. So one of the things that I think the TLT addresses, and before it, there was another cyclodestructive procedure, had pretty good number of experience cases with that. The challenge with that is it wouldn't be a quiet eye. It wouldn't be something that was simple for the co-managing doctors. We'd get phone calls saying, hey, I'm getting inflammation. I got to, need to increase steroids. I got to keep them on steroids longer. I'm having more CME. So this really has filled a niche or filled a hole that otherwise, is not addressing, basically the amount of aqueous production. If you're not addressing that, you're missing an opportunity, in my opinion, to really help many of these patients. So it's something that, there are, I think, misconceptions. There's fear of hypotony, because in residency we hear the story, oh, somebody had a CPC, but and then they had a bad outcome. But I got personally a lot of experience. Other panelists will talk about their experience, and it just is not something that I've experienced. So hypotony has not been an issue. Zero of those. Excessive inflammation. One patient comes to mind, a lady with uveitic glaucoma who had inflammation afterwards. That was kind of a known thing. And so it's just, it really works well. So for me, the majority of the mixed cases that I do, I will combine TLT with it. And again, from a patient standpoint, takes a couple minutes extra, no change in drops, no change in post-op regimen. And over 60% of patients are at target IOP and they're not using drops. They got auto-corrected, but it's drops. I think probably see a little bit different patient population than some of the other panelists, in that most of the people I see are their cataract patients who happen to also have some concomitant glaucoma. But I think we're not treating patients as well as we could if this is not part of our armamentarium. So in terms of complications, a couple little tips. CME, 5%, maybe a little bit less than that. But this also includes people with ERM, people with diabetes. So it doesn't seem to be any different than just the standard cataract populations in my hands. Hyphema, I was, I'm doing the stents and the shunts. One tip that I found is at the end of surgery, if you leave the pressure somewhat higher, it'll reduce some of that reflux. And so, when I first started doing them, wanted to leave the eye soft, it's glaucoma, keep the pressure down. But realized, wait a second, if I raise the pressure, it'll help prevent reflux of heme. So hyphema is probably like 4% now, and that's including with all the other trabecular bypass devices. So I think in summary, from my standpoint, it's a tremendous addition to armamentarium. I think it's way underutilized. It's safe, it's effective, it's cost effective for patients. Reducing the drop burden is a huge area that's being pushed, looking at in the glaucoma realm, and in medicine in general. If we can treat patients' conditions without all the burdens of pills and drops, and it just is going to make things so much easier. So, thank you for the opportunity to share my message. But it's really simple. 3 things: it's safe, it's underutilized, and just jump in and get started. So
thank you, Dr. Heersink. That was a fantastic talk. If you have any questions, again, please submit them through the question and answer function or chat function on Zoom. Do you find that after MicroPulse in combination with cataract surgery, is your outcome affected at all in terms of that wow factor that your normal cataract patient alone is going to have in terms of the visual recovery?
Yes. So the outcome vision wise, no, it's not. It's not having. It doesn't have any impact at all. It does have an impact of bringing the pressure down, which is obviously why we do it. But to answer your question, it does not reduce the wow. I can see, and as kind of progressed and gotten more and more comfortable with it, for somebody who's got very mild glaucoma, I'm using the TLT. I use it with some of the presbyopia correcting lenses, and so that's something that it just works well, and it's safe, and it is not in my hands seem to reduce that. So yeah, the patients are the vision is great, they're happy, and it's it works well. Does not reduce any of that wow factor.
Excellent. So we do have a question. Do you do cataract, MIGS, and TLT at the same time?
Yes. Yes. Yep. So all 3. Yes. So typically, what I've been doing and what I describe to patients is, all right, we're going to do a laser to turn down the faucet. I do a lot of canaloplasty. And so if we do a canaloplasty, to use this gel to flush out your drain, and then we'll put a stent in to keep the drain open. So actually doing kind of all of them. And part of that is, I think, the kind of the patient population we have. The way I see it is people don't, they come from 2 hours, sometimes more, to see us. It's not easy. We get one crack, one shot at surgery, because they're there for the cataract. And if we're going to do things, let's really try to do it, rather than some people have a stage approach of try something and then try something else and try something else. But I figure, do it all in the one surgery, because the safety profile of them are terrific, and the outcomes are that I'm getting are really terrific. So, is it the stent? Is it this? Is it that? I'm not really sure. We have a pretty big database. We're starting to look at that now. But yeah, so I'll do cataract, TLT, canaloplasty, and then one of the trabecular bypass shunts, all in one procedure. And that seems to work well, and is working well from an insurance standpoint as well, in coverage.
Thank you. Thank you. Okay. So we're going to move on to our second panelist, Dr. Rajen Desai. Dr. Desai is a glaucoma specialist in private practice in New Jersey. He received his MD from Stanford Medical School, and he trained under previous American Glaucoma Society president, Dr. Kuldev Singh, and Dr. Sean Lin of UCSF. Dr. Desai received the HEAL Foundation Fellowship in Glaucoma at Northwestern, where he trained under another past president of the American Glaucoma Society, the late Dr. Ted Crouppen. Annually, he performs over 1,000 glaucoma and cataract surgeries and over 100 MicroPulse TLTs. In today's talk, he will discuss how he utilizes MicroPulse TLT in combination with other surgeries. Dr. Desai.
I'm not sure whose phone it is, but I love who I just saw there. Nice to have you here. So I want to tag on everything to what Sebastian said and just add a couple more elements to it. So kind of go through. I'm with, like Sebastian, I have a large referral practice. So people come to me just once, and they kind of go back to the referring OD or MD post-operatively. And so I need to have one crack to get it done right. These are my consulting financial disclosures. So one thing I want to mention here is that it's actually good for good vision. So the stigma, even the one which I was trained in fellowship, is that CPC, this destructive procedure, is only for blind, painful eyes. And so that's what we're taught. And as we learn more and more, we realize, oh, wow, what is the evidence of using it? I don't want to use it on my 20/20 patient who bats to 20/50. I don't want to use it on my premium lens patient because this is CPC. Well, let's look at actual data. So these are published data here. I'm looking at someone who had glaucoma pressure, you can say about 25. And logmar is hard to distinguish. Use my thing down here. You can say their logmar essentially was 20/20 to 20/20 to 20/25. Their vision was good before surgery, and 12 months later, they're still at, on this part of my screen here, they're still about 20/30 or better. That's without correction afterwards. And the pressure reduced from 25 down to 17 on just this by itself. And so this people who don't have cataract surgery or any other MIGS, it's a standalone. It's great for people who have good central vision. And just like what Sebastian was saying, I've noticed rarely any CME. And the CME I do get is people who actually were going to get CME anyway, CRVOs, ERMs. I've had 0 cases of iritis, 0 cases of hypotony, 0 fibrin. In fact, my post-op regimen has changed over the years to now just steroid drops, QAD 1 a week. That's it, no taper. Same regimen I use for an LPI or a YAG or a YAG capsulotomy. There's no difference. It's that benign. I don't put any dexamethasone in the subcons, and I stopped doing all that. Just QAD steroids 1 a week. I treat it like an LPI. In my opinion, I think an LPI is probably more destructive than this thing because there's actually no destroying, making holes in tissues. So it's good for central vision. That's what the data says. Among complications, 61 patients whose all vision pressure was at least 20/30 or better, and standalone doing the MicroPulse TLT. And some had 20% lost just one line of visual acuity. And the studies say, okay, well, 5 were due to a cataract. Well, that's a moot point if we're doing it with cataract surgery. 1 was due to CME. Well, that's very, very small out of 61. That was done pre-op. 2 due to iritis, which is not a big deal, especially with cataract surgery because we're going to give steroids anyway. 2 had unexplained vision loss, but they had severe glaucoma to begin with. So here the incidences are very, very small on exactly on having complications from this procedure. My biggest complaint for MicroPulse TLT over the years is that it's too benign. It's too simple. And I've been cranking up and across the board, increasing my energy from the 2000 milliwatt days to like now 2500 and doing like 5 seconds or sweeping through really quickly to now doing 50 seconds for a hemisphere versus just 10 seconds. So now we've added more and more energy and still nothing happens with the danger profile. It's been that safe. These are my own results. I just could look at, it's always funny when you see papers and say, what do I have? So I dug through my charts, and this is what I've noticed on my patients who are 20-25 eyes. And so here you see that after about 12-month follow-up, their pre-op was 16 on 2 to 3 drops, and now they're 12 on 2 to 3 drops. And these are the settings that I was using. And we'll go over more details about these settings. I know Courtney will go over more details also about using 100 seconds was the main standard back then, 50 seconds per hemisphere. And it's been, those are low settings right now, 2250. We can actually get better outcomes doing it more 2500. We'll talk more about that. So still, I use it on my 20/25 eyes, my 20/20 eyes, and nothing happens. It's been safe. There's always a big stigma. When I'm in the OR, and a lot of the older doctors are using the ECP. And then some of the people ask me, hey, you do this TLT thing, and how's it different from the, ECP? And is it better, or are you doing something, you're a glaucoma guy, are you doing something experimental or crazy? And I'm like, no, guys, actually, it's more effective. It's actually safer. So here's published data on a comparative trial, phaco with ECP compared to TCP, transscleral, we'll just essentially call it TLT, MicroPulse. Actually, this is actually not MicroPulse. This is actually continuous wave CPC, which is still extremely safe. But the purpose of this discussion, it's going to be just the TLT. So still, you have less CME using MicroPulse TLT, less. You have 3 times more using ECP. You have greater pressure reduction. Reasons for failure, more people can have under pressure under 20 using it. The pressure reduction that's not high enough, it's worse with ECP. Who needs further glaucoma surgery? More people with ECP need it. So across the board, whether it's effectiveness or whether it's safety, the CPC, or in this case, MicroPulse TLT, it's safer and less complications than ECP. To the point where I don't even do ECP. Like, why would I? Why do I waste time inside the eye and have any weird sludgy ocular surface stuff getting into my incision? No, I'd rather keep the eye closed and do my CPC first, or I do CPC at the end of the case. I don't need to do ECP. It's a really outdated procedure that does not have, it cannot hold any merit at all when you look at the evidence against the MicroPulse TLT. So that's what the data actually shows. So you'll be more out of trouble by doing this. And so this is a couple things about why some techniques and pearls here. The key thing is you have to use actually a liquid interface. And so here, the biggest reason, this is my fault. When I was doing the G probe, I would never use a liquid interface. I was told to do that, but it's kind of like, nah, that's fine. I'm a glaucoma guy. I know what I'm doing. I'm not going to do that. It's all about focusing the edema of laser. So this laser did not work before. It would cause ptysis and corneal edema because the light would not scattered. Light was being scattered. It would not work properly. Forgive the cursor. This video has been doing this all day. Let me kind of show you what happens when the light is in air touching surface, where the light actually comes onto the actual liquid interface. This is important because during cataract surgery, we're having liquid interface already. This video will do. Just give this video a chance. Come on, it's just a buffering. There we go. So that's not in the video, not underwater. Out of water, under liquid. So the big difference in the focusing of the beam, and when you can focus it, you have better efficacy and less complications. So now we know clearly the focusing beam is much more precise when you actually have a liquid interface. This is now me doing it on a patient. So here's me doing it. You can see the focusing beam on this eye. And now I'm not too happy with how precise that is. So I take now my Provisc. There's always some Provisc or Helon or Visco used after a surgery. I use that because it's sterile. And after I'm doing surgery, I don't want to use some Gonac or anything that's not sterile. I'm not happy with that amount of focusing beam. You can see there, it's not good. So what I do now, this goes very quickly. I'm actually going to be putting the cannula inside the little hole of the probe. This is a small hole inside there with a plug it is. And right there, I inject it in there. And now watch what happens. It's a much more precise dot than before. The video, I'm sorry, doesn't do much justice, but it's one of those things where you have to trust me. The light was much more precise. You're just seeing a lot of glare right now, but it was more precise where it was. I'm able to do the procedure better. I'm doing it too fast. Again, this video is from a little while ago. Don't do it this fast. It's 15 seconds per quadrant. But that's the logic of using your existing sterile, any viscoelastic, put it actually in the chamber itself and put it on the eye. It maintains itself. Otherwise, when you slush away on the surface, nothing gets in the chamber. That's something I learned the hard way of getting. And I started doing that. My outcomes got so much better. This is me doing it wrong. This is, again, a patient who was probably 2 years ago or something. There's a lot of Gonec on the eye. I'm doing it way too fast. So again, we are all learning. As we learn, these settings come from experience. Iridex asks us high volume users, and I love it when the Iridex rep actually comes to us and we go with censored and HIPAA compliant, all the patient charts. We've done dozens of charts and go over what settings we used to what outcomes are there. And this was effective, but this was actually, so this settings are here, 50 seconds per hemisphere, 2,500 milliwatts, that's the duty cycle. But it just was too fast of a sweep. It still worked great for him, but then again, he was, pressure was 40, so it's hard to get this wrong. But it generally goes slower than this. So 50 seconds per, for me, a quadrant or per hemisphere. We'll go over those exact numbers afterwards. Do not do it this fast. So, okay. Standalone really quickly, I'll go here. So here's my procedure doing it on just some patients I just dug up lately. IOP was 22 on 2 drops, and now pressure is 15 on 2 drops. Here are the settings I was using. Again, before, maybe 1 or 2 years ago, we were doing a lot of 2000, 2250. It was great. I mean, these results are pretty darn good, 22 to 15. I'd love to be the drops, number of drops less, but it worked. So now simply, we're just cranking more 2500s now, and now we're really getting a better effect. This is 120, it's a typo here, please ignore that. So a lot of it's just experimenting. I mean, I think like in one sense, this could be like the heydays of phaco. When phaco first came out, it was no good. People like intracap because you're having so much phaco energy, you're burning the cornea, you're breaking the capsule, it's all these things happening. People abandoned phaco in the 70s and early 80s until technology changes, until you use burst mode and duty cycle and pulse mode. And now you're using viscoelastics, and all these elements made cataract surgery, phaco, safer than extracap. Similarly, all these changes of using duration power have made, and torsional power versus longitudinal, all these things that we're learning the hard way, learn from our mistakes, learn from our experience, and you can have a fantastic outcome now. And so learn from what we did before and what we'll do now. Let's go back to area of using it with MIGS. So I like doing this, and maybe Sebastian likes this too. I'm from Texas, so Cowboys and football go together, and of course Sebastian's gonna be all about Crimson Tide. Glaucoma is like being a quarterback, and it's all about risk versus reward. So the more pressure reduction you want, the more risk you have to take. If you want to get the ball down 20 yards, good luck throwing it, good luck running it with it. You're probably gonna have to throw the ball. There's more risk with that. You get sacked, you get interceptions, that's life. That's the life of a quarterback. You guys all watching are quarterbacks now. So in this thing here, classically, we have this. You want a 1 to 2 millimeter reduction additive to phaco alone, low risk, do an iStent. On the other end of the spectrum, you want something bigger, you want an Ahmed valve or trabeculectomy. That's more higher risk, higher reward. And I think continuous wave CPC was a very low risk procedure in that kind of zone. And these positions can change depending who you talk to and what day of the week you see me in the OR. We're used to that. Now there's some outliers. CyPass was an outlier. That's something that had the same IOP reduction as iStent, but with much more risk or theoretical risk if it's done improperly with a corneal decompensation. So there are outliers on this chart. And the question is, where do you want to be on this chart? What is your comfort level? Whether you're an investor, you want stocks or bonds or whatever you want to do, is always about your chance of return and your need for risk. This is the world we live in now. We have HydroStent, we have KDB or Trabex goniotomy, Omni and Zens are right kind of in the middle. For me, I think Ahmed non-valve ClearPath that's probably safer than Ahmed valves and Trabs, and actually probably more effective than the valve devices. And I put MicroPulse right here. Now, where these things are on the chart can kind of change day to day. I did think a ClearPath today, an Omni today, a Zen today, a KDB today, and a Hydrus and iStent. I did all 5 of them today in the OR this morning. But so my positions may change up and down depending what happens. But MicroPulse TLT is really down there. It's like lower risk, arguably, than an iStent or Hydrus. There's nothing cutting, and a pretty decent IOP reduction. I mean, you're not going to get more than just 1 or 2 points. You can really crank it up to 5 or 10 points more. It's a really good place to be on this chart. So what do we do? So it's always hard enough to pick, and this is the whole art of what MIGS device to do. You do iStents, Hydrus, KDB. We have now the Zen. We have the Trabex and the Omni. So it's hard enough to decide. And there's a lot of talks about what we do and on which ones can do what. And for me, I speak for most of these devices, actually. And in all my talks, I say I will not do one, I'll do the other. There's a logic to the madness. It's not just all pick one, everything. When you're a quarterback, you don't just throw to one wide receiver. You have 3 wide receivers. You have your running back. You have your tight end. You have 2 tight ends. You can run with the ball. It's your choice. There's no cannibalization or competition in this area. They all have pluses and minuses, and they all work together. So that's the fun part of me experimenting and trying different devices in different patients. Now you add to that what power of TLT we use. So now it gets even more confusing. So this process happened over hundreds of patients, over many conversations with other doctors, and learning while we're doing it. So trying like using 2000 with 2050 and trying different combinations, 1 quadrant, 2 quadrant, 3 quadrant. How many seconds per sweep? 10, 15, 20, 3, 4, 5. All you can do is keep on just trying it and experimenting. You're a chef in the kitchen, trying this, trying that, and mix and match things together. And you get burned sometimes, and I'll tell you when I get burned, and you kick up, a touchdown and a home run a couple of times, and many, many times. And I'll tell you what, at least I've learned from in my hands of what combination of all these factors have worked for me. And here's my conclusion. I won't go through all the learning pains. I'll tell you just the end of it. The logic is this: you're going to titrate to about 110 to 150 joules. This is done in a clinical trial, experiments that have been done. This range has the best range of having the IOP effect with least thermal damage. So that's the kind of goal we're kind of looking for, total amount of energy in the eyes. And the way you can do that is by doing, just like Sebastian mentioned, you do like the sweeps velocity. So you can do 20 seconds per hemisphere or 10 seconds per quadrant. I do 15 seconds per quadrant personally, and I titrate to 3 to 4 sweeps. I want to stay out of the red. Anything red is bad for me. So I just kind of stay in 1 to 2 to 4 sweeps. Each sweep is 15 seconds. And that seems to be my magic number for me, where I minimize, again, 0 iritis, maybe 1%, 5% CME when I'm doing it with cataract surgery anyway on a diabetic. That's fine. But no ptosis, no hypotony. That seems to be my magic numbers. So here's where I've got it. So my nutshell is this, is that for consistency, in order to make sort of sense, about, I don't know, several months ago or even like a year ago, I started saying there's too many variables, pick one thing only. So I choose now 2,500 milliwatts all the time. 3 sweeps per quadrant, 15 seconds per sweep. That's it, permanently. I'm not going to fiddle with that. I fiddled enough over the years. That's my go-to. And I just change the number of quadrants I do. And that's how, at least for me, I have some evidence-based way of looking and maybe publishing my own data. So we'll go through 3 ways of doing a MIGS: ideal, acceptable, and subpar. You can have a birdie, par, or bogey, depending on what you want to do or description. And we'll describe how I do my cataract surgery first, and then my MIGS first. Whether you do MIGS before, maybe I do my hydruses and canaloplasties before my cataracts. Otherwise, I do my stents and Zens after the cataract is out. It doesn't really matter. After both the cataract and the MIGS is done, then depending on how the surgery went, I decide what TLT settings to use. So ideal, and I decide myself, I judge myself. Was that an ideal MIGS, acceptable, or subpar? So ideal, it's not me. So let's talk about iStent Inject W. This is your ideal guy, iCombat. All right, so he's ideal, searching for everyone. I took a screenshot of him on an AO doing an iStent Inject. So there he is. You see a nice blood reflux coming from this one. But what about this one? All right, give it a couple seconds. There it is. So now this is ideal. We don't always get this. It's luck of the draw. But when you see nice, beautiful pub of perfect position and nice little heme reflux to the stents, you're going to have a great outcome. Hit collector channels. This is perfect. Again, this is iCombat doing it. That's why it's perfect. So if ideal, heme reflux through both stents or limbal blanching, then that's great. Then I only do 1 or 2 quadrants. Again, I titrate based on what I'm looking for. This is a normal tension glaucoma patient. This person's pressure is 30. Pressure is like target is what? It depends. So that's up to you and how much you want to do for the patient. If they're on 1 drop or 2 drops, 3 drops, that's all you. But 1 or 2 quadrants seems enough for me. Acceptable. So heme reflux through 1 stent or no limbal blanching. You guys know what I'm talking about? You know, when you put the IA and the whole limbal flushes, I love seeing that. If you don't get that, okay, you get your job done. It's par. I do 2 quadrants. And if it was subpar, like if I get the eye stent in, it just misfires, the little trigger misfires, like the stent buries into TM like a high myope, or you can't see it, or it's just mangled up in some mess, or it couldn't fire properly, you're tilting and pushing. You know how it is. Those of you guys do eye stent injects, there's ways to, it does not go perfect. All right, so it's poor positioning. In that case, I don't trust that little guy to work properly, and I say, screw it, I'll do 3 quadrants. I avoid nasally. And then there's no voodoo there. I don't want to put heat on a metal object. Again, there's no proof of that. I don't want to be the first to experiment with that. I'm not doing any heat on a nitinol or a titanium stent, hydrus, or even a Zen for that matter. I just avoid putting it all those areas. So that's what I use. 1, 2, 3. Hydrus. This is a nice, again, IconMed's doing an hydrus. So here's your ideal position. Perfect positioning here. All 3 retention arches are visible. This is perfect. Again, if it's done perfectly, 1 or 2 quadrants. If you're too close to TM, we just do 2 quadrants. If you can't implant it, because that happens sometimes, then I just do 3 quadrants and avoid that nasal quadrant. Omni, same sort of thing here. In the interest of time, I'm just going to cut to the chase in this video here. Sometimes there's actually a snag when you do the Omni. I'll just show you what this looks like here. The snag looks like this. Sorry. This is what that quadrant, that half was done well. Let me show you when it's not done well. So here's, and you can watch carefully here. When you're doing the Omni and the globe rotates too quickly, you're actually going to run into some problems here. I'll just go right back here. Let me insert it here. So watch the globe rotate as the catheter goes inside. When the whole globe rotates, see how the whole robe is rotating? You see pressure resistance. That's not good. Well, you can't see too clearly in this video. That's going to actually cause some heme or reflux. There should be no resistance there. So when the catheter feels a snag or bounces back, you've probably gone under the iris or in the scleral wall. That's dangerous if you rip it out. So anyway, if I can do canaloplasty goniotomy both over 270, then I do 1 or 2 quadrants. If I only got the canaloplasty done, which I do a lot for my hydruses, and just half the goniotomy, then I do 3 quadrants. If I couldn't get anything done properly, I couldn't get canaloplasty done properly, or couldn't get goniotomy, then I do 3 or 4 quadrants. This. Zen, same thing here. In interest of time, I'll go quickly. Diffuse bleb, thin stenons, quiet conj. I don't do any Zen. There's 1 or 2 times, you may want to do a Zen. I think one time there was a patient who had kissing choroidals. One patient with aqueous misdirection I had when it was combined. Both patients turned out just fine. They had to be drained by retina, but I don't do it anymore when the Zen goes perfect. If it's acceptable, you have your thick tenons, they're going to fail eventually. Then you do maybe, and this is, you can decide on your own, 1 quadrant. If you have subconjugative, no bleb, no flow, then Zen's not going to work. You do 2 quadrants here. Interest of time, I'll skip all this, but basically I do it a lot with, we can discuss more in case studies afterwards. Results doing with the Zen, ab externo, with these settings have gone pretty darn good. 36 on maximum medical therapy, 15 on 2. Tube revisions are great. That's the different discussions on MIGS, but I do it with tube revisions a lot and with blood revisions as well. So I'll just kind of skip these for any glaucoma people out there want to discuss more about this, but it's a great, great procedure to use. Thanks, guys.
Thank you, Dr. Desai. I think one of the pieces that I took away from your talk is the ability to optimize that procedure for the patient and the other procedures that you're doing on the, at that given time, because, let's face it, it's not a one size fits all, as nothing in glaucoma truly is. And so having that ability to optimize really gives you a nice advantage to titrate for your patients. There was a question, if you do experience any type of subconjunctival hemorrhage or any heme, do you find that will absorb the energy and decrease the effectiveness of the treatment with MicroPulse?
Yeah, it's going to fail. And so that's why I'd be very careful of doing that, like with the Zen. So I typically do when I do it with the Zen, it's the inferior half of the globe. Heme is going to take up the energy. like melanin. So there's no way you can get through the tissue when you have heme in the way. And so, but that's what's my backup. You never know when you're on a blood thinner or they stop the blood thinner for 3 days, they still bleed. You never know what you're going to get with a Zen unless you're doing an open technique approach. And so that's why, yeah, you heme, don't even try. Don't waste your time on doing it on over subcon gene. It's a complete waste of everyone's time, including the patient's time.
So to add on to that, the same question, do you think that maybe you should do the MicroPulse TLT first then, when the eye is in a more quiet kind of white state, as opposed to waiting?
And I tried it both ways. And then now, like I've been at least the settings that we're talking about now, this 2,500, 50 second per sweep, these settings are so powerful on their own that I don't get any hypotony. And I have hypotony before with the Zen. I've had it before. And then kissing choroidals, aqueous misdirection, like the real stuff. Just avoid that. So now, like I've learned the hard way, just through a few rare examples of just doing your MIGS first, and then titrate your Zen afterwards. Titrate your MicroPulse TLT afterwards. Otherwise, you never know what you're going to get. If you half-ass your MicroPulse TLT and just I'll give 2 quadrants, and then you do your Omni, and your Omni can't go in because you're stuck in some situation and you're snagging, or you have all this bleeding, you only do half the eye, not 360, you just missed your chance of doing your MicroPulse. So you can always do MicroPulse at the end. I love it because you can do anything with it. 1 quadrant or 4 quadrants, it's in your hand. It's in your hands. So I love using it at the end of the case. It's sort of like bowling. You try to go for a strike. If you only get like 4 pins, it's okay. You got a second chance. Your second bowling ball shot is your MicroPulse. And that's how you get a strike. It's your spare.
Thank you. Excellent talk. Okay, we're going to move on to our third panelist, and we're going to shift gears a little bit, and we're going to talk about continuous wave as well as MicroPulse in combination with other surgical glaucoma procedures. Dr. Courtney Bovee is our third panelist. Dr. Bovee is a Harvard-trained glaucoma surgeon practicing in the greater Tampa Bay area. Her desire to push the needle forward with new technologies has allowed her for less invasive techniques and better outcomes. We're excited for her to share her experience in utilizing both MicroPulse TLT and continuous wave technology in a wide range of glaucoma patients. Dr. Bolvay.
Thank you so much. It's such a pleasure to be here tonight, joining such a wonderful group of colleagues. I just am so excited to talk about this technology. During fellowship, I guess I'll go ahead and start with this, my financial disclosures. During fellowship, I trained at Mass Eye and Ear with Dr. Latina and Dr. Pasquale. And similar to other people's experiences, residency was this technology, the CPC, was reserved for eyes that were blind and painful and just had no visual potential. So you have a blind, painful eye, what do? Do you put some retrobulbar alcohol in, or do you CPC them, or do you enucleate them? So in residency, I had a really good plastics guy, so we largely enucleated it, and this technology was really never exposed to me. So I get to Boston, and I work with Dr. Latina, obviously the gentleman who invented SLT. So he kind of open-minded surgeon, will try just about anything. And he obviously loves to titrate settings, loves to titrate powers. And that obviously for him resulted in the SLT laser and then a variation, quite a few iterations of lenses thereof. And then I kind of contrast that experience to Dr. Pasquale, who is very well known in the glaucoma community, does a lot of work with pseudoexfoliation. And I would kind of call him your traditional trab glaucoma guy. So it was neat to see where a traditional glaucoma doctor who's very trab only was utilizing this in great eyes. And then also Dr. Latina, who's going to push the bar forward and try just about anything, use the same therapy. What did they have in common? All of these were in eyes with good visual acuity. And so that's kind of what I'm going to hammer home tonight is the CPC laser is something that we can use with great eyes that were traditionally we might have waited for the glaucoma to progress to then do something with a higher side effect profile. So, and kind of similar to the other comment tonight, I think really there's not a lot of data in terms of looking at this technology, and I say continuous wave, but it's interesting. My experience over the past, say, 7-8 years has been nothing but incredibly positive with great outcomes and, just a paucity of side effects. So I kind of just continued these treatments because they're working so well. So I guess for me, when I kind of approach a patient, I think this is a great option. So how do I kind of look at a patient in the lane and then take that experience when I'm in the operating room? So for me, do I choose MicroPulse versus continuous wave? Honestly, it's a pretty simple decision for me. And a lot of times it comes down to, can the patient get blocked or not? And that I refer to my anesthesia colleagues. So if they're comfortable giving a peribulbar block, I'll go ahead with continuous wave. If not, then I'll opt for MicroPulse. You could get a little more kind of granular in your approach and say, if I want a more robust pressure response, opt for continuous wave. But I think the great thing with all these technologies is we can retreat if necessary. So I'm kind of a simple person, and my practice kind of leads to the more simple I practice my glaucoma, the better outcomes, because there is variability. The two practices I've been at have been in Florida. So we have a couple different things to consider. We have high expectations because there's, we're really pushing the needle forward in terms of cataract outcomes. And it's high volume and it's over multiple different areas. So I've been going between, say, 3 to 4 offices, anywhere from 5 minutes to my house to an hour and a half from my house. So, that kind of variability between offices means in different staff, how do I make things easy? So we'll talk about this in the settings in terms of my OR staff recording my settings, and also in the post-op consideration. So for me, let's keep it simple with the continuous wave. And we'll talk about this more in my talk because I've just had great results and not even really seen a need to opt for the MicroPulse just because my outcomes have been so favorable with the continuous wave. So I typically do 2000 milliwatts, 2 seconds, 20 shots, 270 degrees, just largely avoiding the 3 and 9 position. So if you think of 2s, you can kind of figure this procedure out. Equally spacing out the shots. I really enjoy the illuminated probe because that really confirms where I'm at and that I know I'm treating the target tissue. So like I said, I've always opted for continuous wave. It's just kind of been what's worked for me. So I think if we take a step back and think about what are we doing? Well, the MicroPulse is great because it shrinks the collagen and sclera and allowing more area to the supraciliary space. And this obviously is going to then provide a pathway for aqueous and its suprachoroidal space. So let's think about continuous wave. It's kind of like MicroPulse plus. We're also treating the ciliary processes, the pars plana, pars planata, and the vasculature that feeds it. So with the continuous wave, you're getting kind of that upstream, turn off the faucet effect. So I think where we can kind of go with this technology and have been going for the past several years is not just stop at those blind, painful eyes. Let's use these eyes, as Dr. Desai said, and eyes with great acuity. Those are your mild to moderate glaucoma. As a glaucoma fellowship trained doctor, I love tubes and traps. They're a lot of fun. And it's interesting, more in practice, I kind of am scratching my head, like, where are these big surgeries? Well, I'm not doing them as much anymore. And I think because I'm utilizing these tools earlier on to get better outcomes with a better side effect profile. That being said, in my practice, I'm humbled on a daily basis. Glaucoma is a very humbling disease, and this is still a great option for those refractory cases. Do you want to inject retrobulbar alcohol? I'm going to have to look it up, Google it. I don't know what dose. I don't know, where to get it. So this is something I already have in the OR. Why not just opt for that to keep a patient comfortable if the pressure is high? And once again, if I can avoid cutting a hole in the eye, I think my patients are going to be happy with me. So this is a wonderful technique. So kind of as I mentioned before, when I was in residency, I kind of compare this to the Ford. It was a good technique. I think as a surgeon, it's my duty to kind of offer the sequential approach to get my patient with good outcomes to that, Lamborghini that then is going to have a better outcome, and kind of a shinier result. That being said, as you look at the picture, we always need help along the way. And so that's why this talk kind of focus on what about CPC plus. So there's lots of things that we need to think about in terms of how do we be successful getting to that path of the Lamborghini. Like we talked about with MIGS, I think it's a great option that we're offering both turn off the faucet and open the drain. Dual hit hypothesis makes a lot of sense for patients, makes a lot of sense for our referring doctors when we explain what we're actually doing from an anatomic perspective. I think one of the nicest things about this, and then some of the, like say the goniotomy, is we can do this as a standalone. So when I have a patient in front of me that has severe disease, pressures in the 20s, 30s, 40s, I can do this instead of an OMED. I can do this after an OMED. I can do this after a TRAB. So I think it's great that we can do it as a standalone approach. And that's where, I think we continue to move the needle forward with some of the MIGS and their additional indications. As the other two doctors talked about this evening, incredibly safe. When I look back at my patients over the past 7-8 years, I can think of a couple cases of CNV, and that's probably less than 2 or 3. And once again, wide range of patients that qualify for this technique. As mentioned before, I love that the continuous wave has that dual mechanism. And because we're still in that same safety profile, I think in my hands, it works as well, if not better, than the MicroPulse. So in terms of the MIGS, I think, in my personal opinion, glaucoma is so exciting because we are just at this renaissance. We're at the edge of the cliff and the doors are opening. So we now are kind of at that neat spot where we don't have to say, we're going to cut a big hole in the eye, put some medicine on it, and melt the eye and hope it doesn't bleed or get infected and you lose the eye within 24 hours. So now we can say, let's use the CPC laser, either MicroPulse or continuous wave, in conjunction with our MIGS. I'm a huge fan of the Cahook and the Omni. I stent, you're limited to at the time of cataract surgery, same as Hydrus. The Zen is a great procedure. In Florida, it was really late to get coverage. So I've just been really, really happy with my results of, continuous wave CPC with Omni and Cahook, that I really haven't needed to reach for them that often. In my clinical practice, I've started to use a lot of Durista. And I think as we continue to offer our patients more options, this is where the CPC really is absolutely wonderful. For me, I've really changed my approach to a glaucoma patient in my chair as a much more conversational approach. I have medications I can put on the eye. I have medications I can put in the eye. I have big lasers. I have little lasers. I love to use SLT lasers. Obviously, I train with Dr. Latina. And so I think this more conversational approach is, some patients absolutely do not want a needle in their eye. Some patients are really, find a laser pretty palatable. So this kind of works with whatever mental barriers they may have to whatever treatment options I'm able to provide them. That being said, I am a glaucoma surgeon, and I still have, like I said, those cases that humble me. So I've already done a TRAB. I've already done a tube. What next? Do I put another tube in? Well, we all know inferior tubes are great when I get cornered into nothing else. And I see Dr. Desai smiling a little bit. He knows you put them in, and then that third tube, as I'll talk about in a little bit, is just, you don't like it, because when those third inferior tubes start exposing and eroding, they just don't do well. There's not a lot of conch to pull back over, and I don't love it personally. So why not we have a tube superiorly first? Wow, we could follow this with CPC. Great option. I had a very close friend is in retina practice down in Palm Beach, and he just didn't have anybody to send the patient to. Well, this is a Canadian patient, for some reason, had Canadian healthcare down in Florida, enjoying the sunshine and sand. And the guy had 2 buckles, and he had to take the buckle out. So I just did not want to get in there, figure out in this patient, what did the scarring look like underneath that. So for me to even consider a TRAB or tube in a patient that might go back to Canada, not a great option. And on top of it, he's driving 4 hours to come see me. So that being said, CPC was a brilliant option. And it was neat because I really had a nice dialogue with the retina surgeon and said, this guy's uninsured or self-pay. how do we take care of him? This was a perfect option. So I think for those kind of tough cases where you don't know what's under the conch sometimes, you don't know what they've had, this is a really, really beautiful option that offers a great side effect profile. And, you know, as I said, we're really in this renaissance of glaucoma. I mean, it is the new sexy. So who knows what awaits us? And I think the neat thing about the Iridex technology is we can use this at any point. It's not like your eye stent that you have to use in conjunction with cataract surgery. I can use a micropulse or continuous wave at any point in my treatment paradigm, and once again, repeat it if the effect is not robust enough on my first go at it. So once again, as kind of the settings, I like to keep things simple because you don't know, is there going to be a lot of turnover with staff or my refractive coordinators or surgery schedulers? So the easier, the better, in kind of my opinion. So some of this, similar to Dr. Desai, I've changed over the years. When I first started, I was literally not seeing any inflammation, almost to the point of, I don't even know if I need a steroid, but I'm going to do it just because I'm treating myself. And so I can sleep at night. A lot of what I do is so we can sleep at night and not get woken up of, oh my goodness, I forgot to do that. So for me, I said initially, like, I'll just do a steroid 4 times a day for 2 weeks and be done. And it was working great. The practices I've worked with, a lot of times they want to streamline things with our cataract surgery patients, just so the refractive coordinators don't get confused. And they're doing one thing for my glaucoma patients and another thing for, you know, these high expectation refractive cataracts. So I think let's simplify it, make the practice kind of be uniform in what we're doing. So it's what I do. The only thing I differ is just do 4-3-2-1 by week and steroid antibiotic when you're done with the antibiotic, and then you're done. And then the steroid just continue on for the full month. That's if I combine it with an incisional surgery. So if I'm going to do a MIGS, eye stent, a hydrus, a cahook, I am going to put an antibiotic on board, obviously. If I'm going to do standalone CPC, the great thing is all I need is a steroid. So that's very, very simple. I just continued on with the taper just to simplify things, but I think you could reasonably do 4 times a day for 2 weeks. So a couple of different things. You know, when I was over the years, I've really refined my SLT powers, and I do a lot of SLT, and I do very high power SLTs, but I have very good results. So I've had to kind of adjust my CPC settings over the years. And once again, I think this is a technology that you just kind of adjust as you go. Something to really be mindful of is the pigment of a patient. So your Caucasian patients or Scandinavian PXF patients, you can go ahead and crank the energy up for these. I'd be fine with 2,200 and maybe going up to 24 shots. And once again, I'm talking continuous wave, just because I've had really good results with that. And the other 2 doctors touched more on the MicroPulse this evening. Your pigmented patients, your African Americans and your Hispanics, use a lot of caution. I'd say dial down, similar to SLT. I'm not going to go to town in a very heavily pigmented trabecular meshwork. Same thing with their continuous wave. Not too substantially, but I just wouldn't probably go up to say 24, 25 shots. I'd keep it at 20 or below. Like I said, titrate for your success. You know, something that really doesn't come up in either the literature or the studies is when I always do my CPC first, and then I follow with whatever incisional glaucoma procedure. So whatever MIGS I'm going to do. I think there's probably something to be said for I'm going in and I'm eyeing all that pigment that I stirred up out of the eye. So I think that might cause some theoretical kind of cleaning out of the angle. I don't know. That's just an anecdote from myself. And then once again, I think similar to the MIGS of these are not the refractive cataracts, the light adjustable lenses that say my partners are doing. These are glaucoma patients and some of the patients that I'm doing. So pre-op expectations with goniotomies. You know, a lot of times I actually am excited when I see heme because I know that means I've reached anatomic success. Not that the patient's going to, you know, have any different end result, but it just might take them a little longer. So I think always, in my opinion, in my hands, under promise and over deliver. So just let them know you have an advanced disease in some of these cases that, you know, it may take longer to get back to your baseline vision if, say, you're doing it with a MIGS procedure that you might expect heme in the early post-op period. But that goes away. And in the few cases I've had, it goes away. If not, you IA in and out. That's been probably less than 2 in my experience, but you'll have a great end result at the end. So just as a quick kind of case to run through, like I said, glaucoma is a humbling procedure, and those of us that kind of go into it, this is the case that, you know, kind of, had I not trained where I trained in fellowship, I would have had no idea what to do. Truly no idea. So this is a 53-year-old African-American gentleman. Remember him well. He came in with 3 tubes, and actually I isolated this to one eye, but it was both eyes. So he had 3 tubes in the one eye. His pressure was in the mid to high 30s, and he was on everything. Diamox, you name it. I mean, I could have thrown on Neptazine in there, probably not going to help, but he was on absolutely everything. And I truly did not know what to do. Well, fortunately, I trained where I did, and I was fortunate to work with Dr. Latina and Dr. Pasquale. So I was using, you know, continuous wave CPC. So even if I look at it from a real estate standpoint, I don't think there really was anything I could have done at that point. Could I have done a goniotomy for, you know, a few degrees? Probably not going to be tremendously effective. So for this, obviously I chose CPC. And this I could kind of even titrate between the tubes to get a better response. You know, I kind of pull up this case as an example too. What if we had used CPC earlier? Would we have necessarily needed those 3 tubes? And I question, probably not. And so that's where I really challenge people to use out-of-the-box thinking, because this is great technology. Use it earlier, and that way you're not getting to that 3-tube patient. And once again, this is a technology that allows for a really nice quality of life and a great conversation with the patients in terms of what are they going to be amenable to from just even a psychological standpoint. So the great thing about the Iridex CPC laser is you can retreat. If I didn't get to where I need to go, if I went from Ford to Mercedes, I might be happy. You know, it's not so bad. I still get to where I need to go, and people turn a few heads. But if I really want to turn heads in my Lamborghini, I take them back. No big deal. And I can still get to that pressure that I really truly want. Once again, if this is that patient that's, you know, he was young, he was in his 50s, I may still need that extra space to do a 3rd. I'm probably not going to do a 4th tube, but, you know, I still may need that extra conj available down the road. So if I think about this technology earlier in the patient's disease course, I think we're better off long-term. The neat thing about, like I said, this renaissance in glaucoma is, like I said, I'm in Florida, and there's a huge co-managed population of my patients here. So I can actually co-manage easier knowing I've done something. I've done interventional glaucoma rather than just put them on drops. If I send somebody back to a referring doctor that I just said, okay, here's your Lumigan, or I'm going to add Comagan, that referring doctor is not tremendously happy with me, I may lose that referral source because they look at it as they could have done that themselves. So why did they waste that patient's time, energy, and possibly even risk that patient never coming back to them? So this allows me to do something tangible, treat their pressure, and work more collectively with my referral sources. Thus, kind of everybody wins at the end. I always say a rising tide in the harbor elevates all ships. So let's work more collaboratively rather than independent silos. And, you know, I think anything with, you know, glaucoma, like I said, we're really undergoing a lot of technology. I've been lucky enough to kind of push the needle forward. Sometimes I've actually had to take a step back and say, am I crazy? Am I missing something? Because this is just such a great option and works really well in my hands. So at different points in my career, I've gone back, looked at my outcomes, looked at my patients, and said, this really is a great option. I can safely say that, you know, when I retrospectively look at the patients, they have better vision, or, you know, better vision if there's a cataract, stable vision if it's standalone, lower pressures, fewer drops, and they're well maintained. And I think I kind of challenge anybody that, looks at technology that might have been in that blind, painful eye, mental block for them. Do a couple, wait a few months, look back at your data, look back at your results, or, say, ask somebody that has great results, ask for their, patient numbers and do a, chart review. For me, it's really been a wonderful, technology, and very, very incredibly happy utilizing this.
Thank you, Dr. Bovee. That was a great talk. At the moment, we don't have any questions. So if anybody does have a question, please submit it through the Q&A. I have a question for the panel. Are there any MIGS procedures or other interventional glaucoma procedures that you wouldn't combine with MicroPulse or CPC?
For me, no, Sebastian here. And I've done all the ones that are, I don't do Zen, but other than that, I do all the other ones. And so, yeah, no issues with combinations of any of them.
That's a great question. And I absolutely love to kind of understand what I'm doing and kind of from a pathophysiology standpoint. The one I would say, like your tubes and trabs, I always say, let them have time, let them work. So I would do them as a standalone procedure because I don't, trabs are highly variable. Even in the best of hands, you could be 0, you could be, 50 on day 1. I don't know. So I think let those bigger glaucoma surgeries do what you want them to do. And then you can follow this after you've kind of gotten the response that you're expecting, several months out. There was a patient, quite a while ago where we got in the OR, we were going to do a tube, and turns out, like I talked about, the conj was just miserably scarred. And we said, this is great technology, let's use a CPC. Unfortunately, the patient had already received anesthesia, and so we weren't able to consent them for a CPC at that time. But that might be even something for me going forward. Maybe I just consent everybody for this. If, say, I go in for an incisional surgery, I can't do it for some reason, this is a nice backup.
You're on mute, Dr. Desai.
Sorry, I down to cortisone. And the lucky patient, white, thin conj, elderly, the white, a Zen can work pretty darn well. So again, like Courtney, I don't do it with my Zens anymore, unless the Zen is obviously failing. Yeah, then I do it. If it's anyone from brain surgery, it's like the Zen's going to fail. I'll do it in those cases. But otherwise, yeah, give the Zen time to work. Sometimes you get lucky in the right kind of patient.
Very good. Dr. Desai, in your talk, you compared ECP to both MicroPulse and CPC. Why do you think that the results were better on the transscleral approach than they were on the intra-op approach that ECP has?
So I mean that I've never done ECP before, but like I can imagine that when you're a comprehensive, with respect, if you're a comprehensive surgeon and you're watching the ciliary process crinkle up, you're like, okay, I better stop right here. You're not looking at the function. Like, where are they? Just because things look crinkled up, they could still be producing aqueous humor. So you're titrating it based on the appearance, on fear. You're not titrating your power based on actual dysfunction. And so that's why the fear is why people don't do enough energy, because you don't want to destroy the eyeball. So I think like when you see things here, the good thing about CPC or TLT, you can't see anything crinkling up. I mean, nothing does crinkle up. And so you can just give all the power you want to and focus on outcomes. And I think that's why that there's no fear in TLT. It's safe.
Sure. Do you potentially think that maybe it's because it's really only affecting aqueous production and you're suppressing it as opposed to enhancing any of the uveoscleral outflow?
I mean, I try to take as much evidence-based medicine as possible. I'm not sure exactly how much that's, unless I see published papers and in vitro that's saying that. I don't go into speculation. There's enough speculation in voodoo and glaucoma that I try to keep as much evidence in my talk, published papers. That's what I try doing. I try sticking to peer-reviewed stuff as much as possible. So
fair enough. We do have a question. If there's a bleb, can you probably treat only 2 to 3 quadrants, avoiding kind of that, conjunctival area of the bleb?
That's a great question. I'd say yes. In theory, here's the wonderful thing about glaucoma is you don't always know there's a blood there too. Sometimes it's only when you're in there looking at goniotomy that you see the sclerostomy from the previous surgical PI. So I have treated over the top of a bleb. If I know there's an actual, like, you know, obviously, why am I back there? Your blood failed and it's probably scarred down. So anatomically, I think you're okay going over that area, but I would avoid it if possible. So usually in my surgery schedule or whoever's kind of recording for me, there's a port where I say like, did I avoid the area of previous surgery? And I will if I intentionally know it. But I like a lot of transparency. And like I said, sometimes I don't always know there was a, you know, I know what Dr. Desai thinks, but there is times where you say, I can't even like necessarily see it because it's scarred down. It wasn't one of those like really avascular, you know, tissues that we hope to see sometimes. So.
Right, and there's no need to get like a bleb leak for no good reason because you're putting this thing over a bleb. Like, you know, why you have 3 other quadrants out there? Like, why go mess with a bleb? Like, I agree with Courtney. Just avoid it. No need to go over it. You know.
Very good. We have another question. It says, why do we avoid bleb? Is the distance to the ciliary body more? So probably, you know, looking at just anatomically where we are in terms of the limbus and the ciliary body, are we avoiding the bleb simply because of the risk of perforation, or are we avoiding it, you know, because of the distance to the ciliary body?
I'd say to avoid the area of conge over the top to make sure that has a good integrity of tissue.
Very good. Very good. Well, I'd like to thank the panel. I think this was a wonderful webinar, and I know there was a lot of information shared. We will have the recording of this up on the website, and we will send out that link so people can go and review. If they have any questions, we'll have the contact information for Dr. Bolvay, Dr. Heersink, and Dr. Desai. But we'd love to thank you for joining us this evening, and have a wonderful evening.